Welcome back, everybody. Thank you for joining us this afternoon. I'm going to hand over to the chair of the first session for the afternoon, Danielle Lavallee, who is the Scientific Director of the Academic Health Sciences Network. So thank you, Danielle.
Thank you so much, and I echo the welcome back from lunch. It's a true pleasure to be here. I would like to begin by acknowledging that I'm actually joining today from the unceded territory of the Sept people. So I'm a bit away from home today, and it is my pleasure to serve as the chair for this session, which is focusing on the population health impacts of public health measures during this time. But before I introduce our panelists and their sessions, just a few quick reminders. The first is that the session is being recorded and will be publicly available following the symposium through the BC Academic Health Science Network YouTube channel. Please do remain muted during the presentations to reduce background noise. If you do have questions for our panelists over the course of the presentations, please use the chat function to put those questions there. I would encourage the panelists to respond as they're able, and hopefully we'll have time at the end to touch on a few before we wrap up. We will try and wrap about 2:05 so people have time to make it over to the breakout sessions. But without further ado, on to our wonderful panel. We have 6 amazing presenters today. Each have 10 minutes to touch on the impact of public health measures with a focus on specific populations. I'm just going to quickly walk through who the presenters are and their focus of their presentations, and then we'll quickly turn it over to our first presenter, who is Kate Smolina. She's the director of the BC Observatory for Population and Public Health at the BC Centre for Disease Control. She's going to kick off the panel by talking about the overall population impacts. She'll be followed by Jeff Redding, Professor of Health Sciences at Simon Fraser University, Director of the Indigenous Governance Center, and the First Nations Health Authority Chair in Heart Health and Wellness at St. Paul's Hospital. Jeff will be following Kate, presenting with a focus on Indigenous peoples and communities. Kelli Stajduhar, Professor in the Institute on Aging and Lifelong Health and School of Nursing at the University of Victoria, will be presenting on seniors and senior care. Rhodes will follow. He's Professor of Exercise Science, Physical Health Education at the University of Victoria, and he'll be presenting on children and youth. Kathy Rush will follow Ryan. She's Professor of the School of Nursing at the UBC-Okanagan, and she'll be presenting on rural populations. And finally, to round out our panel, we'll hear from Antonia Avina, Senior Scientist of Rheumatology for Arthritis Research Canada, and he'll be presenting on specific patient populations. So we have a lot to cover in a short amount of time. So without further ado, I'd like to hand the virtual podium over to Kate.
Can you hear me now? Yeah?
Yes.
Okay, and can you see the slides?
Yes.
Oh, good. All right, without further ado, I had a very narrow topic, so I tried to do this fast. As you can probably imagine, there are many ways to measure overall population impact of public health measures. You can think of it as the what, and there's lots of choice there. You can look at the direct COVID metrics around cases, and even within that, there's a lot of choice, whether you're looking at reported cases or perhaps true cases or more severe cases. One could look at deaths, again, COVID-related or excess mortality, and of course, there's a whole slew of metrics related to the unintended consequences of the public health measures that span the health, social, emotional, economic aspects of our lives. And once we pick a metric, then we have a further choice. Do we look at within BC, in Canada, or more globally? Do we look at specific point in time or changes over time? And then do we segregate it by age, by sex, and population subgroup? And we'll hear more around how the public health measures have impacted different members of the population as part of this presentation. So I'll certainly leave it there. In the interest of time, this is what I will cover with you today. We'll focus on reported cases and putting BC into the national and global context, specifically looking at trends over time up until the end of yesterday. Cases do tend to be the one metric we all look for when we wake up in the morning. That is one metric that's used in a lot of modeling and a lot of decision making. So despite its flaws, it is still probably one of the most sought after figures on a daily basis. I also wanted to highlight the COVID-related efforts that are currently underway at BCCDC, so that you're not left with the impression that there's only monitoring of the cases. There's certainly a lot of work ongoing. The backbone of us being able to keep the finger on the pulse is, of course, laboratory testing and surveillance. There's a team focusing on BC epidemiology and surveillance of COVID cases and deaths and hospitalizations and ICU admissions. We have a partnership with our academic partners on the mathematical modeling, looking at how different scenarios might affect the epidemic curve in BC. You may have seen this year a prevalence study, first results that were published a few months ago using the leftover blood samples to understand the antibody prevalence in the population. There is syndromic surveillance ongoing, looking at signals in other data sets that might indicate another outbreak that can be helpful for that early detection. We're looking at mobility metrics to understand how the public health measures have impacted the way the population moves. There is a big effort involving many partners, too many to list, around the assessment of the unintended consequences of the public health measures that CDC is part of as well. And finally, and that's where will bring us to today, is putting BC EpiCurve into national and global context. So I'll just give you a flavor of some of the slides that we're monitoring on a weekly basis to understand how do we fit into the national and global picture. This panel illustrates to you how BC compares to other Canadian jurisdictions. The y-axis is the same everywhere except for Quebec. So you can really see how the epi curves have been very different for different provinces and territories, both in magnitude and the profile, really highlighting the idea that in Canada we haven't had a single epidemic. It really truly has been a series of regional epidemics, and every jurisdiction has its own story to tell. We are looking at BC and neighboring jurisdictions, both Canadian and US. This is geographic proximities, and you can certainly see from this graph that BC is at risk of importation from outside of its borders. The prevalence is certainly much higher in a lot of the US states neighboring us as well. We look at BC versus EU, and specifically in the EU, what we've done in this graph, we actually centered the epi curves around the most recent reopening date, which was phase 4 for most countries. And what you start to see is that about three or 4 weeks into the most recent reopening, the cases start to rise. They start to rise at a different pace in different jurisdictions. At the top there, you see the second waves that have been experienced in France and Spain. Towards the bottom of is the part of the club that BC is there. What we are seeing in BC is also what a lot of European countries are seeing as well after reopening. Another metric that's been widely used, and especially around travel restrictions or allowances, is the total cases per 100,000 population in the past 2 weeks to understand that recent point prevalence. So this is just to give you an idea of how BC stands relative to our European counterparts. On the left, that's the big graph. So we're about halfway, and we have consistently remained below EU average. And on the right, you see how we compare to our other Canadian jurisdictions in the recent growth of cases. There are also many challenges for trying to understand this global patterns and global picture. One of the main ones, especially at the beginning, where the multitude of public health measures were employed all at once, which made it very difficult to understand the impact of any single measure on the COVID case count as well as the other consequences on the population. So this figure gives you a sample of countries from different parts of the world. The y-axis is different. The point here is very much to compare the profile of the epi curves. So here you will see that BC is quite similar to that of Australia or Japan, but for example, would be very different from Mexico or US or France for the moment. Another challenge is, and something I wanted to highlight, when you're looking at a lot of the epi curves and the case counts, is something to keep in mind is the different and change in testing criteria, which does make jurisdictional comparisons tricky, and even tricky comparisons over time within a jurisdiction because that criteria has changed. So this is an interesting graph that our World in Data team has put together, and it's those epi curves that you've seen in the previous panel slides just now on the same graph, but they're color-coded based on the test positivity rate. So the blue is curve is really where you want to be. It's below 3%. The idea being that the jurisdiction is likely testing enough, so you're likely detecting enough cases. You're more likely to have epidemic control versus if they're in the orange or the red territory, there's likely other cases in the community that are not being caught, and will be harder to gain that epidemic control for the outbreaks. Another challenge would be the inconsistent level of disclosure of data. There's underreporting of COVID cases and deaths, and that level of underreporting, of course, differs by jurisdiction and also over time. However, lots of opportunities as well. The gradual reopenings provide an opportunity to look and get more insight into effects of different measures because the reopenings were not done all at the same time. The various approaches across jurisdictions provide a way to do natural experiments. For example, in the US, the policies around masking have been vastly different, and it does provide that avenue to look at what the effect may be. And then we can learn from that, what works in different settings and what we can learn and apply here in BC, and that's what we've been doing over the past 6 months, and we hope and we will continue to do. There's also an unprecedented level of publicly available data, which presents many opportunities for new analyses. Something you've seen Bonnie Henry present during the public briefings would be, for example, tracking mobility. Google released the mobility data for the whole world, including BC, so we've plotted it next to our epi curve and the daily precipitation for Vancouver. And you just to understand how did the population move as a result of those public health measures. You can certainly see that the residential time you spent in the residential areas went up as expected, and then time spent in workplaces, transit, retail went down, but now we're slowly coming back to those levels of before public health measures were enacted. If you're interested in keeping in touch and following the international trends and how BC compares, there is a tab on the BCCDC dashboard that has international comparisons. We're working to fix a little bug that made the graph quite squished, but it is there. And also BCCDC surveillance reports, the ones that are produced on Thursday, so closer to the end of the week, include these summary figures for the new and cumulative cases and deaths for the national context, as well as the international context as well. So those are updated every week and released publicly. Just want to say a big thank you to my colleagues and hopefully on time. Thank you.
That was fantastic, Kate. And you're right, we did give you a very narrow topic to cover in 10 minutes. So thanks for rising to the challenge. With that, I'm going to hand it over to Jeff. Jeff, if you're ready to present, I'll pass the floor to you.
Thank you. I'm just getting my, there's the slides right there. I guess I can just advance them myself. Let's see what, okay. Yeah, thank you very much. I'm going to report on a work in progress. It's essentially a seroprevalence study that we're undertaking with the Immunity Task Force, a national study looking at Indigenous journeys through COVID-19. We see this as an opportunity to improve future public health readiness and also to advance Indigenous knowledge. So in addition to kind of responding to the pandemic itself, we hope that there's a legacy that will address an outstanding gap in surveillance and public health research with respect to Indigenous peoples, and try to unify some of the research that's been going on and to build upon CIHR-funded research capacity building that's undertaken for the last 20 years or so. If I could. The first slide here just is a reference to colonization, and I just wanted to acknowledge that, you know, I'm presenting from Coast and Strait Salish territory here. I'm actually Mohawk from Tyendinaga First Nation in Ontario, And I'm really pleased and really honored to be on Coast Salish territory where I kind of work, live, and play. This slide talks about colonization in the 17th century. And, you know, any discussion about pandemics wouldn't be complete with respect to Indigenous people if we didn't talk about the colonial intervention. And, you know, that idea that there was a political economy that was evolving in these nation states. And what brought with it was famine, pestilence, and, you know, the medicine chest clause of treaties actually acknowledged that there had to be an Indigenous focus on responding to things like pandemics. And so we don't have enough time to go into it, but I think it's important to recognize in this slide that the colored portions of this map are described as possessions, be they British or French or Portuguese or Spanish. And most of British Columbia, all of British Columbia in this map is not even acknowledged as being sort of, it's terra nullius, empty land where only Indigenous people lived at that time. Try my next slide here. So this is a paper that we had published in the Washington Post in March 31st of this year. And, you know, we made the point that the global pandemic with respect to Indigenous people exacerbates deep-seated health and socioeconomic inequalities. And in many communities, services like potable water and housing are chronically underfunded, in addition to the need to travel to long distances, in many cases, to access anything beyond basic healthcare services. So we sort of characterize this as kind of a perfect storm for a pandemic. And we've been very pleased that Indigenous communities have gone into lockdown and responded to the threat. And because there is a historic context to all this. And but it doesn't mean that we're very concerned that, you know, coming up with the fall and the winter months and the crowding in houses and all the other determinants of health, that we want to be ready with data to be able to track this. If we're looking at the other conditions driving the pandemic, I guess the next slide would be, you know, in this audience, we know that cardiovascular disease, diabetes, chronic lung disease, all predispose. And this is showing that basically at this time, early in the pandemic, in the United States, Indigenous people were about twice as more likely to, you know, die and have the illness of in relation to the population distribution. I'll just go to the next slide there. And again, we see that the burden of obesity almost doubles the risk for COVID-19. Just going to the next slide. We do have this context of engaging with Indigenous peoples that is made explicit by the Tri-Council Policy Statement on Research Involving Indigenous Peoples. That's Chapter 9 of the TCPS. And essentially what this does, it actually makes it explicit from an ethics policy that we need to engage Indigenous peoples in research and knowledge creation that affects them. And that is different from mainstream in that, you know, individual privacy and consent is required, but it goes an extra step in looking at the collective interests in the creation of new knowledge around health and well-being. So what we have adopted, and it's been something that CIHR has also promoted, is this notion of two-eyed seeing, the idea that you would have sort of Western-based scientific excellence paired with Indigenous perspectives on health and well-being and relevance to community interests. So this notion that we have a synergy between the two. And so we take research from, you know, being excellent in terms of addressing important community concerns, but also employing methods and tools that make it excellent science. And together they become outstanding in terms of actually developing research knowledge that allows us to move forward. Now, if we, that was attributed to Elder Marshall from the Mi'kmaq territory. So this is an important slide because it's a process that we're engaged in with the Immunity Task Force, the Public Health Agency, and other players. And we have engaged this process of an Indigenous advisory circle that comprises about 30 people across the country, representing political organizations, Indigenous communities, academics, and government. And from that, we developed a proposal that looked at genomics and genetics, vaccines and immunization, data integration, and interventions. So that was kind of like the moonshot. There's a lot there to be doing over a very brief period of time. But what we focused on is a seroprevalence study. And we don't have a longitudinal cohort that we can add evaluation onto. So we have to actually create the cohort and then through that process undertake biological samples as well. So what we have here are a two-stage process. Stage one, the baseline study, is going to be 13 different regions of Canada and reflected in 9 CHR-funded networks for Indigenous health research. And those 9 networks are going to be engaged with communities around the advancement of new knowledge to balance the community relevance with the scientific excellence. That'll be the baseline study. And then we will follow that baseline study up with repeat measures at 3 months in a cohort that's actually determined from that baseline study. So the baseline study will be 18,000 individuals from 6,000 households stratified by age and gender, looking at children and youth, adults and elders. So it is a big undertaking. And this is my last slide here. It's really hard to take all this complex work and put it into a 10-minute soundbite, if you will. But this is my attempt at talking about what I call seamless information exchange. And it's really important to look at this picture. I won't walk through it because I don't have the time to do that. But the central question is, who governs biological genetic information? And if we're looking into the future and we see this COVID-19 as an opportunity to respond to a very pressing health concern, which, we are very focused on providing data in the context of risk, but also in the context of access to vaccines in the future. But what we leave behind after the pandemic has run its course, we hope will be a changing landscape that will, prevent and allow communities a voice in terms of monitoring ongoing surveillance, but also looking at advanced research questions around public health and social policy. Thank you.
Thanks, Jeff. That was a phenomenal presentation, and I appreciate you putting it both in historical context as well as the focus on the importance of community engagement. I think we have a lot to learn from the work you're leading. That leads us to our next presenter, Kelli. Kelli, I will hand the floor over to you. We just need you to unmute.
Sorry. Yeah. I just.
Okay, you can hear me now?
Yep.
Great. Okay, thanks so much. I'm just getting my slide deck going here. Okay, you can see the slides all right? Yeah? It's okay? Let's see. Sorry, I'll just go like this. Okay, so thanks very much. I'm coming to you from the lands of the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, the Esquimalt, and Wasanic peoples on whose historical relationship to the land continues to this day. And I'm going to say that right off the bat that I'm starting this talk feeling very grumpy. And I'm feeling very grumpy about talking about COVID-19 and older adults, because older adults have really been disproportionately affected in a negative way throughout the pandemic. So my comments I'll put into that context right off the bat. So you can't see my slides, can you? Can you see my slides? There.
We can see them. I'm wondering if they're not transitioning from one to the next. We still see your main slide.
Are you just seeing my title slide?
Yes.
Okay, yeah. So do you have my slide then? I'm not sure why they're not sending.
I'll try and troubleshoot in real time, but if you go up to the top of your slide, you may be able to change the presentation mode.
Yeah, just let me see. I'm just gonna stop that for a minute, sorry.
And it might be if you have dual screens, you might just have to show them in the slide deck view as a backup. There you go. Now they're changing.
They're changing now?
Yep.
Okay, so you see the 31 dead in 3 weeks slide. Yeah. Okay. So I work with populations of that maybe we perhaps don't think about enough or as much as we should, older adults, including those that live in long-term care, those who are in need of palliative care and their family caregivers, and those older adults who are rendered vulnerable on the basis of structural inequities such as homelessness and poverty and marginalizing experiences like mental illness and substance use disorders. And I'm sure that all of you were as horrified as I was, though I wasn't surprised when the most harrowing story came out in Montreal from the residents Heron. This was a place that was marketed as an upscale luxury retirement home, and public health officials found essentially the facility deserted and residents laying in soiled beds with a number of people who had died. We might be proud in Canada to be #1 in hockey. And can you see this slide? Yeah, okay. But we're also #1 for the percentage of coronavirus deaths in care homes. And that's not something so much to be proud of. And I don't want to be all negative. Like, I think COVID-19 has provided us with some wonderful opportunities to spend time with families, and all of those public health measures in some ways have been really good. But they haven't really been so great for residents in long-term care and older adults in general. In June of this year, the Royal Society released a really important report on the status of COVID-19 and the future of long-term care in Canada. And I'm not speaking exclusively about long-term care here, but long-term care has become kind of the pivotal point to demonstrate some of the issues that we see in the care of older adults in our healthcare system in Canada. This report is basically a compilation of several research studies over the years. And those of us who have worked in seniors care and older adult care for as long as I have and longer are not surprised by what we are seeing happening to Canada's older adults in terms of the COVID-19 pandemic. The pandemic really has only really exposed, I think, more generally to the general public, long-standing, widespread and pervasive deficiencies that exist in the long-term care sector and in our care of older adults more generally in Canada. And, you know, those of us that have worked in the sector for a long time were not really jumping up and down when the Premier of Ontario said that their response to COVID was to launch another commission. And that's because if you look in that Royal Society report, you will see that we have 50 years of data and task forces and commissioned reports and panels that tell us what we need to do to reform seniors' care in this country. And we have ample evidence to tell us how to do it. And so as we collectively grasp the enormity of the troubling living conditions for Canada's older adults and the resultant deaths due to the pandemic, we also have to think about how such a tragedy might have been prevented or at least minimized in the first place. It's been almost 20 years since Roy Romanow led the Royal Commission on the Future of Healthcare in Canada, highlighting an urgent need to build Canada's home care programs. In 2009, the Canadian Healthcare Association published a roadmap for how to get there. And it is really unfortunate that these calls for a robust home care system have by and large been ignored. What we have in Canada for home care is kind of an inadequate piecemeal and patchwork system where few Canadians get the care that they want or need. And I guess, you know, of the $264 billion that we spend each year in Canada on healthcare, estimates are really that only $3 to $9 billion of these dollars is directed towards home and community care. And that's kind of surprising because the development for care closer to home is pretty much the priority of almost every government in our country, certainly in our province, and in most developed countries around the world. So if we actually want to improve care in the context of pandemics, we really need to get serious about how it is that we actually provide a care system that keeps people in places that keep them safe. I don't want to end, I don't want to have like an entirely negative end. The good news is that we have some really solid evidence to tell us what to do. And thankfully, in British Columbia, really, I would say that we haven't seen the same kind of issues for older adults that we've seen in Ontario and Quebec, for example. And that is directly related to Dr. Henry's very early action and order that really prevented, that shifted the kind of way that we deliver care work in institutions for older adults. So, you know, people were not allowed by order to work in more than one care facility, for example, during the pandemic. That there is absolutely no doubt that that has absolutely at least minimized the spread of COVID-19 into the care home sector. But there are lots of people in the community, including the people who, particularly people who are facing older adults who are facing living in poverty and who are homeless, who have also disproportionately been affected by the pandemic. So what happens beyond the pandemic is, I think, in some ways really up to us as a society. COVID has given us an opportunity to rethink how we care for older people in our society, and in our country and in our province. And there really isn't much of an excuse, I don't think, right now to turn our backs on that. And to not really think about that now is really kind of acknowledging that we don't really care. And I don't think that we really want to do that. I think that we have some really good kind of solid foundations with some really excellent science and people who work in our health authorities in the province where we also could provide a model for how we provide excellent care to older adults wherever they happen to be in our healthcare system in British Columbia. Thanks very much.
Thanks, Kelli. I appreciate those remarks. And I think you're right in ending that we will all be on the other side of this at some point and we'll be accountable for how care improves. And so I think that's a call to action for all of us to really focus on the inequities that COVID has brought to light. I'm going to invite our next speaker to the virtual podium. Ryan, I'm going to turn it over to you now to go to the other end of the age spectrum and talking about youth and children.
Great. Thank you very much. Yeah, so I will, I'm going to chat about physical activity during the pandemic restrictions here in Canada and focus on families as well as a little bit on adults because we have two data sets that I can share with you today under this short time. So it's probably everybody on the chat knows that physical activity is one of the more important health behaviors one can engage in with reduced chances of at least 25 chronic health conditions, many of these that interact with COVID-19. And unfortunately, we in high-income countries, we certainly have a problem with meeting physical activity guidelines. These are 150 minutes of moderate to vigorous physical activity for adults, and about 60 minutes of the same per day for kids and youth. And we are pretty dreadful when we're looking at actually the child results of this. So about 15% of children and youth are meeting those guidelines. And it depends how we measure people, of course, as you can see on this slide to the right. But ultimately, if we measure with self-report, about 50% of our population say we're meeting guidelines. But if we slap an accelerometer on people, it's down toward 20%. So certainly a challenge. And this is, of course, pre-COVID-19 conditions. Now, explaining why people do what they do in terms of health behavior like physical activity is massive. And in fact, I teach an entire course on this. So this little slide is meant to just sum up all of the different socio-ecological issues that we're dealing with with something as complex as human movement, from biological to interpersonal and psychological to environment, regional and national policy, as well as global issues. And I'm going to share a few variables on these sort of ones to the three, the individual, interpersonal, and environmental, when we talk about correlates of physical activity during pandemic restrictions. So physical activity was challenging before. Promotion of physical activity was very challenging before these restrictions. But as everyone knows, when COVID-19 was declared a pandemic in mid-March, we basically had physical opportunity for physical activity as well as social opportunities just collapsing. And so this is a survey of almost all major sport and physical activity associations. You can see that almost all of them were affected. And at least 50% are saying that they're going to be affected moving into the next year. The restrictions and the social distancing restrictions, of course, have altered a lot of opportunities and programming lessons. Things are starting to bounce back here in the summer, but of course, we're heading into the fall and who knows what's coming next. So not surprisingly, some of the early reports from other countries around the world were showing that screen time was up, physical activity was down, and particularly moderate, vigorous physical activity, which is in the health range that we're so concerned about from my first slide. There's a few mixed findings out there. So Europe had where walking was up, but again, MVP was down, MVPA. So what about Canada? Well, I'm going to show you some results from two surveys that we have in Canada to look at comparisons to various other countries, as well as what might be correlating with the physical activity. About this, these data sets were about 2 months into the pandemic, but there's still evidence to suggest that they're quite compelling even right now. And what I've got below, as you can see, is this mix of publications. These are the actual peer-reviewed papers that are now in press or actually out with page numbers of the data I'm about to show. So we had two very rapid samples of population samples of adults as well as parents, so adults responding for their children and youth. And this was recruited through a third-party marketing research company, and ultimately is generally comparable with Canadian census in terms of some of the major demographic indicators. So it gives us a little bit of a snapshot. I will note that this is self-reported physical activity, so think back to that second slide I showed, and so it's going to be a little bit usually above what accelerometry would show. but hopefully equalized out across questions for people. And all the predictor variables were basically validated measures, but we don't have really the time to get into it. So this is just quick informatic of the data sets. As you can see, we're looking at middle-aged adults on average, but a nice spread of the population, and also a nice spread of parents as well. Dog ownership will come in a moment, so you'll know why I brought that up, because it is related to physical activity, particularly when people are getting out and about. You can see it's about a third of the population of Canada, which is actually accurate. And we had a nice mix of different physical activity profiles as well, as you can see below. So a fairly representative group of people, at least to look at variability. And this is what we saw with adults when we asked before the pandemic restrictions versus 60 days after. And as you can see, our results are looking very similar to China and the United States and some other countries. And I know Google published results as well as Fitbit. And so ours are sort of very much the same as that. Of course, this is MVPA, which is the most concerning physical activity, the one most linked to health. So we're looking at about a 46-minute decline. But that doesn't tell the full story. I think the better story is looking at the profile of people and how they change. So you can see on the far right, at least a third of the sample were active before and kept on going. But we have some interesting groups in between. So we had on the left where it says unsuccessful transition. This is a group who were physically active at guidelines and actually fell apart as a result of the restriction. So that's a really concerning group. We had this kind of neat group that was very small of adopters. These are people who were inactive but became active after the restrictions. And then this group called breach and repair. This was a group who actually weren't active as a result of the restrictions, but found their way back to physical activity. So it took a few weeks or so, but they eventually got back to their patterns in a different form. In terms of child and youth movement, what I want to point out here is the top right group. And this is all the physical activity behaviors on the top of this graph. And as you can see, all the outdoor activities have been compromised. A couple of the indoor play activities have been better, but parents have been reporting that their kids are doing a lot less outdoor activities and a lot more indoor screen time and social media use. So we're replicating here the stuff we're seeing in other countries. And these are the correlates. This is with adults. So you can see that it's actually quite a complex group when we look at the different factors. So we've got some socio-demographic factors, the ones you would expect, often with physical activity, some that are related to COVID-19. So social distancing was negatively related to physical activity, those who were engaging in it the most, as well as those who felt a threat of getting the coronavirus. And then we have our usual assortment of individual factors that are quite important. Some social factors, such as this adopters group was kind of interesting. It tended to be women who were looking after their children in the home. So they were getting more active as a result of this. And dog ownership is almost always a correlate of physical activity. So we found that in our sample. One of the interesting things is how important home physical activity related matters became. And I think this makes sense given the restrictions. But home equipment was a significant predictor, as well as finding home physical activity programming, such as physical activity programs on YouTube and things like that. We didn't see any neighborhood factors with the adult sample, but we did show that with the child and youth sample. So those who are in apartments and small dwellings, high density living, were the most affected by physical activity, perhaps because of the absence of a yard or the absence of a lot of recreational possibilities. We see the same sort of social factors. Parental support, of course, is very important to physical activity generally, and it was even more important during the pandemic restrictions. Dog ownership as well as a predictor. Boys seem to be more active than girls. It wasn't a large effect size, but it was statistically significant. Younger parents were more active with their kids, and household income was a predictor, just like the adult sample. So the key takeaways here before I stop would be that not everyone reduced their physical activity, but certainly the older adult group, when we look at the predictors, were the ones who were most affected. So that's kind of echoing what Kelli was saying. And so we do need to think about messaging for safe older adult physical activity, particularly as we're heading into the winter. The typical individual level predictors of physical activity were actually relevant here. What I do want to point out here for people who aren't in exercise psychology is that often attitudes about the benefits of physical activity, like that slide I showed at the beginning, that has very little to do with people who are active. Most people all agree to that. And the big differences are around those who are finding enjoyment in it, those who are identifying with it, those who have got habits in place, and those who have good planning skills. So these are things that we continue to work on to promote physical activity, and they're particularly important during the shifts in the pandemic restrictions. And home physical activity options seem extremely important in this new age, and so we do have to think about these alternative forms of physical activity programming. And then finally, for families, children, and youth, outdoor activities have really declined across Canada. I think in BC here, particularly with Dr. Henry's messaging, we've been quite good about trying to get people out and to be active, but we have to continue to push that message about the importance of outdoor activities because families are less outdoors than usual. Girls may have been affected more than boys, so there might be some targeted messaging possibilities here. And of course, helping families to support their kids becomes essential. And we recently released Canada's Guide to Healthy Movement for Families. The reference is down below, and I'd be happy to share that later. But there's lots of resources there to help families get active. So thank you very much. And these are just my contributors on those projects.
Ryan, thanks so much. As a mom to a 5-year-old and somebody who's hanging on to her exercise regimen, that resonated with me. And I know there are some questions that popped up in the chat box for you, so you may want to take a peek there.
Okay,
let's transition to our next presenter, Kathy, who's going to be presenting on rural populations. Kathy, I'll pass the panel to you. I think you just need to unmute.
Share your screen.
There you go.
Go to Zoom. Share your screen.
We should be able to hear you now, Kathy.
Right here. And oops. Here, is that right?
Perfect.
Okay.
Oh, shoot. You've moved it around.
I'm not sure that I can move here. I'm not moving it.
Slideshow. Play from start.
Okay. Great. Sorry about that. I think I'm ready to go here.
Yep. You should be, we can see your slides.
Perfect. Perfect. So I'm really pleased to be here. And I'm coming from the territory of the Silex, Okanagan Nation here at UBC-Okanagan. So I'm very delighted to be able to present a little bit of our work on rural populations during COVID. And I'd like to just start with saying that where people live matters. And as other presenters have talked about, certainly inequities and social and structures and socioeconomics and power, land, all contribute really to perpetuating some of the disproportionate disadvantages of some populations, such as rural populations. Where really up to 25% of British Columbians live, and these BC rural populations are they tend to be older, and they include about 1/3 of our BC's Indigenous population. And you'll see here that I've identified some health disparities, and many of these have been mentioned. Jeff, I know, mentioned a few of these, but these are greater in our rural populations than our urban populations, and their health outcomes are poorer really for our Indigenous populations than for our non-Indigenous populations. Rural populations also experience healthcare disparities. And again, I've highlighted some of the well-known disparities, but I would like to draw your attention really to the inadequate infrastructure that we often see in rural communities, such as transportation and high-speed internet, which are so essential really to support health needs, particularly the high-speed internet now during this time of COVID. And on the right of the screen, you'll see marked disparities between the access to high-speed internet at between Canadian urban, rural, and Indigenous communities. So what has been the impact of COVID-19 on rural population, and have the disparities increased? Well, it's hard to say, but to date, there has been a lack of Canadian and BC published evidence for COVID's impact on rural populations. Much of the data that we do have has been aggregated. It's been disaggregated according to sex, to age, but not really according to the urban-rural continuum. There is some just early evidence from the US that has compared rural to urban counties in terms of their COVID case rates and their COVID case fatality rates. And so you'll see in this figure here along the y-axis, it's a measure of rurality. So the greater the rurality, as we move from left to right, we actually increase the level of rurality. And so you'll see here in blue that as rurality increased, that COVID case rates decreased. And as rurality increased, that COVID case fatality rates increased. And so that just is an indication that even though there were fewer cases of COVID in these rural counties in the US, that when they did occur, that there was a higher incidence of mortality. And now this is a US health system and not our Canadian BC healthcare system. But since COVID, digital health disparities have also widened. And so a recent August report from the Canadian Internet Registration Authority tells us that urban internet speeds have nearly doubled, while rural speeds have plateaued. And rural Canadians are 10 times slower, have 10 times slower the median upload and download speeds than their urban counterparts. And you'll see from this report just some numbers that were cited as well to reflect this disparity. So I emphasize some of these inequities and disparities just to bring us to some of the work that we are doing with our Rural Health Equity, our research cluster. And we just really formed in January, but our vision has been really to reset the inequity landscape, and by promoting rural health and healthcare equity by leveraging technology and social enterprises. And so we began, like I mentioned, early in the new year, but of course, COVID then descended upon us, and we then ended up pivoting our work, our community-based research, to take advantage of learning more from our communities about what their challenges were during COVID and their use of technology. And so we were interested in the first few months of COVID. So we invited adults 19 and older from rural communities, so across the health authorities from various ethnic groups. Our Qualtrics survey was open for about 6 weeks and used fixed and open responses. And you'll see on the right the particular content categories that were included in the survey. And I just want to draw your attention to 2 of them because we don't really have time to talk about more than that. But we did ask our participants to rate the impact of challenges that they faced during COVID. And they rated it on a scale of 1, no impact at all, to 5, extreme impact. And so presented here are the proportion of participants who rated each challenge as somewhat, quite a lot, or extremely impactful. And you'll see, of course, there's no surprise at the top of the list, the biggest challenges being limited access to family, friends, social groups and support groups. This was followed by challenges around limited access to healthcare services, including mental health services. And then you'll see that financial challenges were also quite high on their list of ratings, with limited income opportunities and also just difficulties paying the bills, rent, mortgage. Also, even some basic challenges with securing food, water, childcare was also a challenge. And you'll see with respect to internet that although 98% of our participants had internet access, that 1/3 of them had limited access to stable internet, going back to my earlier slide. And we haven't had an overwhelming response from participants about this particular issue, because it just did really affect a lot of their daily activities, like schooling their children at home and just being able to engage in at-home leisure activities, no live streaming, those types of things that were so difficult difficult. And this one participant who actually even talked about a decrease in the internet speed during COVID. So just to talk about how some of these findings might be synergistic with some of the other themes, I think of great value would be certainly looking at comparing the impacts and unintended consequences of public health measures between rural and urban communities. As well, there's, I think, an importance to examining really rural communities themselves. So comparing rural communities and how they are doing in terms of the impacts of COVID, because a rural community is not a rural community is not a rural community, but indeed they are very unique in terms of their population size, density, services, governance, those types of things. And so those types of comparisons, I think, are extremely important. And there's also the need to understand longer term impacts of COVID. Certainly, we looked at challenges. We haven't looked specifically at health outcomes, but I think it's important to look at how these challenges change over time. And we are planning a follow-up to this particular survey, but to look at how the challenges change over time and what the impact is on health outcomes, social, physical, emotional. And the other, in terms of developing and implementing public health measures, our rural communities certainly tell us that rural is not mini urban, but it is important to hear the voices of rural populations. And I just wonder about whether our kind of universal public health measures, in some instances may require some adaptation and tailoring to the specific unique contexts, rural contexts. I turn now quickly to telemedicine, because telemedicine, I know that this gets into health services, but it was an important component of our technology work. But we did ask our participants, and you'll see that 88% of them had access to telemedicine, but only 44% had used it. And during COVID, there had been about a 30% increase in their use of telemedicine compared to pre-COVID. Were they satisfied with telemedicine? You'll see here that overall, yes, but there is room for improvement, that 75% felt comfortable communicating with healthcare providers, and nearly 90% certainly indicated that they would use it again. However, only 2/3 of them found it to be an acceptable way to receive healthcare services, and also felt that the quality was satisfactory, meaning that a third of participants really felt that perhaps it wasn't acceptable or was the quality satisfying. So in terms, obviously, our technology and telemedicine is probably here to stay. It's quite ubiquitous now with COVID. So certainly there is an ongoing need from a health services perspective and even a workforce perspective to continue studying the impact of technology on rural populations, trying to maximize the use of technology. But of course, the internet challenges are a major barrier in rural communities. And I know that there's work federally, provincially to try to rectify that, but it still is problematic. Much more work is needed on improving telemedicine satisfaction, its acceptability and quality, and not just for the recipients of care, but also for providers. Providers are also challenged because we've also been surveying providers in rural communities as well, and they are challenged with just being able to again, have the necessary bandwidth that they need, and they oftentimes will drop to the lowest common denominator of telephone, which isn't always a satisfying way to have care or to provide care. And the other final point that I just wanted to leave us with is just the importance of probably looking at creating and testing hybrid models of care, simply because we know that COVID is going to be with us for a while, and looking at best practices around looking at various models to and gearing them really to rural communities as well for maximum outcomes. So I'd like to just acknowledge that our funding was provided by the UBC-Okanagan Research Excellence Cluster Program, thanks to our research team and to the support and participation of our rural partners and participants.
Thanks, Kathy. That was really fantastic, especially given that you were able to pivot so quickly to provide some really rich information for moving forward. Similar to Ryan, you had a couple of questions in the chat box. In the event we don't have a chance to get to them, I'd like to turn your attention to that. Okay, finally, to round out our panel today, Antonio is going to be joining us to talk about special populations. Antonio, I'm going to turn the podium over to you. And Kathy, you may need to click at the bottom. Yep, perfect. Thank you.
Hi there. Can you see my screen or?
Not yet.
Okay. Give me one sec. Share my screen. Uh-oh. Are you able now?
Not yet. It's just showing with your name. We do have your slides. If it's easier for us, we can post your slides for you. Will that work?
Yeah, I just have a change. Let me see. No, actually, yeah, I have to sign out and then sign in again, but I actually will ask you to show the ones I send you, even though I changed a little bit, but that's okay.
Okay, there they are. And if you just say next slide, Kat should be able to move them if you're not able to.
Yeah, let me just go back to the Zoom. Okay. Thank you. So without further ado, I'm the last but not the least, I hope. So I would like to present a research fund that we are about to start. This is a work in progress, and this is probably one of the largest and most ambitious on the COVID-19 in BC, I would say. The reason is because we will be having access to all the COVID-19 cases in BC. And I know the funding was for BC initially, but we will do Alberta. We were in a process on refurbishing a new team grant that we had been using to actually include Alberta data using the same analysis approach that we're going to show you. Next slide, please. So our target population is actually immunosuppression people. I am a rheumatologist, a practicing rheumatologist, and one of the biggest questions that patients came up with that is, should I continue my treatment or should I stop my treatment? At the moment, we didn't have, and we still don't have a clear answer of those. And our fear was, if you stop your treatment, you will probably flare and you will end up in hospital, and therefore you will have a high risk of getting into access to potential contacts. So, and then we expanded, well, we're not in rheumatology, we are not the only population who has immunosuppression. So, and then we started looking at the prevalence of population immunosuppressed, and the only report we found, a population-based, was a survey from the US telling us that about 3% of the general population are in immunosuppression, mainly women, whites, and elderly people. This has been mainly because of greater longevity, meaning people having access to better care, transplants, and more use of more novel agents, including biologic therapy or immunomodulatory agents. So therefore, this use of these immunosuppression or immunomodulatory agents, which I'll explain in a minute what are the difference between them, has increased overall in the last 40 years, and especially in the last 20. So the rationale is that there is no evidence enough to suspect that the immune system plays an important role in COVID-19. Therefore, severe manifestations of COVID-19, such as acute respiratory distress syndrome, are provoked by a major immune inflammatory response, referred now as a cytokine storm. And therefore, deaths associated with this are associated with this immunomodulatory response. Next slide, please. So therefore, immunosuppressed patients may be more susceptible to COVID-19, as they usually are. People with immunosuppression are more likely to have risk of infections, which is actually one of the leading causes of mortality in these populations. However, given the role that cytokine storm plays in these complications of COVID-19, there is also the possibility that immunomodulatory agents, specifically like hydroxychloroquine at the time, methotrexate, or biologic therapy, who has been even proposed as a potential treatment for these agents, will decrease the risk of evolving to severe infection. And therefore, we needed to answer this question, and we selected 4 target populations: autoimmune mediated diseases, which include rheumatic diseases, multiple sclerosis, cancer, specifically those who are more likely to have cytotoxic drug exposure, including lymphoma, lung, breast, and colorectal, but that could include any other type of cancer. And also disease-mediated immunosuppression, like chronic kidney disease that is not necessarily related to drug exposure, but a natural exposure to immunosuppression because of the disease itself, as well as transplant recipients, both solid and organ and stem cells. Next slide, please. So that's our target population. So we wanted to find first answer to 2 important questions: to quantify the risk of COVID-19 associated with immunosuppression. We have 2 hypotheses. One, the immunosuppression will increase the risk of having COVID-19. And also, hypothesis 2 in this aim is that infection may be affected by different characteristics as we have described or heard in the previous presentation, including sex, age, socioeconomic status, rurality, indigenous populations, etc. And number 2 is to assess what happens once you have the disease, if you were exposed to immunosuppressive agents or immunomodulatory agents. Immunomodulatory agents are agents that actually do not provoke immunosuppression, but just regulate the immune system, not the same suppression as cytotoxic drugs. And for this aim, we have 2 hypotheses. Immunomodulatory agents, and I'm gonna go again, like imagine hydroxychloroquine is one of those, compared to like azathioprine or all those cytotoxic drugs used in cancer. So immunomodulatory agents will decrease the risk of severe complications, including hospitalization, ICU admissions, and death. We also hypothesize that the other spectrum of the immunosuppression, the cytotoxic drugs, will have the opposite effect, having more severe complications. Next slide, please. So for this, we plan to do a case control study using a population-based design, using administrative health data from BC to encourage others who have been talking during the day in different presentations, how difficult is having access to BC data from pub data. There was a commitment for the call made by Michael Smith for this rapid response research program to facilitate and accelerate the access to population data. Happy to report that I got an email while I was traveling last week into the Yukon that my data has been approved and it will be available very soon, probably in the next week or 2. And that took us probably 2 months. And I'm very proud to say that they've been doing an amazing work. They respond in emails in the middle of the night. So with Alberta, we're repurposing a data access that we already have. So in total, we will have access to 9.5 million people. So we'll have all cases in BC and Alberta who has been tested positive for COVID-19. And then we have 2 sample controls. One, which will be generated from the general population from up to 10 matching, randomly selected from the general population, matching by age, gender, and rurality, or geographical location. And also a control sample 2, in order to deal with different selection biases that are inherited to this population. Because people who get tested could not have different patterns versus those who decided not, there are intrinsic factors associated with being tested. Therefore, we wanted to use this as a control sample 2 to address potential selection sample controls. So the exposure in these design is people who have been received immunosuppressive medications, cytotoxic drugs in particular, as well as immunomodulatory agents. The list includes 120 drugs that we will classify in two main groups. And the exposure will be divided in the last year prior to being tested or being diagnosed with COVID-19 in periods of 90 days based on the last year. Next slide, please. So I define the exposure will be for immunomodulatory agents like biologic therapy, like interleukin-6 inhibitors, TNF inhibitors, hydroxychloroquine, methotrexate. And the other exposure big group will be cytotoxic agents. The outcomes, as mentioned before, is serious outcomes, which include hospitalization, death, and admissions to ICU units. All these derive from the administrative health data available in both provinces. And next slide, please. So since administrative data do not have all the data that it would need to actually model properly and decrease biases, we also ask permission to the government to give us access to this population to survey them, to address some of the limitations that are not present in the administrative data, including socio-demographic data, excuse me, like education, marital status, race, etc., which are not available. Also smoking status, previous vaccinations, occupational history, prevention behavior that people have. We have the hypothesis, and we have been tracking different registries around the world in rheumatology that have shown actually that they have less risk of infections compared to the general population. And it's very likely that people self-isolate better than the general population. However, we need to assess this as a potential confounder. Also beliefs and behaviors regarding exposure to COVID-19 as well as vaccinations. I have to happy to report also that we have created and engaged patient partners that have been part of the development of this survey, which has been a tremendous value for us to address properly having their input in the design. And this is something that Arthritis Research Canada is very proud to be in partnering in the long history with patient partners. Next slide, please. So we have collaborators across universities and provinces, and universities in BC include UBC, Simon Fraser, and the University of Calgary. We have a interdisciplinary approach with new collaborations, new scientists running other research projects, and we're actually planning already link data that are useful for both projects or multiple projects that are needed. We will link our data with renal populations, transplant populations, oncology, hematology, and new collaborations that are coming up after this two-day symposium. We already connect with them because we will have the data that they need and they have data that we need. Also, we have, as I mentioned before, patient partners. We created a group of patients from different diseases that we're targeting. So we will have their input in the design of the survey and the interpretation of the survey, as well as dissemination of the results. We are convinced that this is one strategy that will facilitate knowledge translation as we have done in the past. Next slide, please. So potential implications. This is a population-based study that facilitates generalizability. We'll have high quality, real-time evidence to support the Canadian rapid response to the pandemic and probably targeting the second wave interventions. We will have enlarged vulnerable populations. We will intend to inform targeted preventive measures to specific isolation measures, priority testing, priority vaccination, and perhaps early treatment. And most importantly, for these populations, we want to understand the effect of these medications used to immunosuppress to guide them their use. As well, an important implication is the linking survey with administrative data that will have to help us to identify novel protective factors and move the research agenda forward by linking external data sources by self-report and addressing the limitations of the administrative health data. Next slide, please. So I didn't go into the details on the analysis plan. I don't think that was the purposes, but if anyone is interested, we'll be happy to share that separately. I would like to acknowledge our research team, which is vast and very important in both provinces, but mainly I would like to acknowledge the funders for the prompt response and the excellence in being attentive to responding to this important need for the general population. Michael Smith, and got a recent grant from the BC Support Unit to facilitate knowledge translation and the patient engagement in this research. And I think I'm done.
Antonio, I appreciate you for wrapping up the panel. And I just want to extend my sincere thanks to all of the panelists for today, as well as the conversation that was happening in chat. I know we need to transition now to the chat or to the breakout sessions, and Kat has gracefully put the links into the chat box. So I will wrap this up. Again, my thanks, and we will see many of you in a breakout room shortly.